And thank you everyone for coming this evening. So, it's traditional for inaugural lectures to include something of a timeline, setting out the new professor's smooth and logical journey to this point, which is a problem, because my journey to this point has been neither smooth nor logical. But a wise person told me recently that the thing about careers is they only make sense in retrospect. So what I want to do today is to make retrospective sense of my career, to explain not only how I found my way from developmental biology to palliative care, but also to explain why this frankly illogical journey has really made me the scientist that I am. So, the illogical journey starts at UCL, where I was a medical student, and I did an integrated BSc in developmental biology, a subject that did and does fascinate me. And I had the luck and privilege of working with a giant in the field, Lewis Wolpert. Lewis was not only a brilliant scientist, he was a brilliant science communicator, and this combination absolutely inspired me. Essentially, I wanted to be like him. But the most important thing that happened that year was that working with Lewis, he planted a seed in my mind that, you know, maybe I could be like him. I thought like a scientist. I had good scientific ideas. And at the risk of sounding incredibly over the top, that year was it was a scientific awakening for me. It was my first taste of the kind of intellectual freedom that an academic career can offer, and I knew that that was what I wanted. But I also knew that I wanted to be a doctor. So I finished medical school and got through my house jobs and SHO jobs, which I think it's fair to say I didn't enjoy very much. I spent quite a lot of that time feeling rather lost. And then I found myself at the Royal Marsden Hospital, which is a specialist cancer hospital in London. And for the first time as a clinician, I loved my job. I felt as though I could see my future. This was what I wanted to do. Now, there's no doubt that retrospectively, this clarity came because I worked with an extraordinary man, Martin Gore. Martin was a giant in the field of medical oncology. He combined a razor-sharp intellect with the most extraordinary warmth and affability. He was always cracking jokes, always laughing. He was a generous man and a generous mentor, and I explained to Martin that I wanted to be an oncologist. But what I really wanted in the short term was to do more research. I was desperate to get back into the lab. So with Martin's help, I secured essentially my dream PhD fellowship, which was at the Institute of Cancer Research, working on breast cancer stem cells, a new and very exciting new area that promised to revolutionize how we thought about metastatic cancer. As with all PhDs, there were bumps in the road. I ended up working with Matt Smalley. So at the time he was a postdoc, and he's now professor in Cardiff, and we worked together on identification of stem cells within the developing mouse mammary gland. So essentially I was back in developmental biology. And working with Matt was brilliant. It was fun, the research went really well, our results were actually groundbreaking, and according to what you might consider to be the usual metrics, my PhD was extremely successful. But there was a problem, and it grew as the months ticked by, which was that increasingly I questioned why I was doing it. I questioned the value of my research for society. This is my Uncle Bobby. So at the same time that I was doing my PhD at the Institute of Cancer Research, Bobby was receiving treatment for metastatic cancer at the Royal Marsden. And for anyone who doesn't know, these buildings are side by side, they're basically twins. So often on a Tuesday, which was the day that he had his chemo, I would leave some experiments running, sneak out of the lab and go and hang out with Bobby for a couple of hours while he had his chemotherapy. And we'd chat about this and that, just passing the time. But over time, it became clear to me that the sorts of things that were on his mind, they were not the things that we were addressing in our lab next door. And And over time, it dawned on me that the bit of oncology that I loved wasn't oncology at all. It was palliative care. So I left. I left oncology, stepped off the academic ladder, not knowing if I'd ever get back onto it, and found my way to palliative care. From my first day as a palliative care registrar, I knew I'd made the right decision. I had found my clinical home, and I'd certainly found my people. But there was something missing, because in my heart I knew I wanted to do research. The trouble was I didn't know how or where or with whom. I had a PhD in stem cell biology. I was training in palliative medicine. You can figure that Venn diagram out. And once again, I felt really very lost. And then one day, completely out of the blue, I received an email from another giant. And it was Irene Higginson. Irene said in her email that she'd heard of me. She knew I had a PhD, and she had one of these new NIHR Clinical Lectureships available. Now, the thing you need to know about NIHR Clinical Lectureships was that you had to be a trainee, in this case in palliative medicine, and you had to have a PhD, and there were not very many people around who fulfilled both of those criteria. She asked me if I was interested. I can honestly say that that email changed my life. It was a sliding doors moment. I slipped through that door and started a new chapter in my academic career here at the Cicely Saunders Institute. I want to pause to say something about Irene, who has been my mentor for more than a decade. Irene's reputation as a world-leading scientist is well recognised and obviously well-deserved. But maybe a bit less appreciated is Irene's extraordinary legacy in terms of capacity building. I think there are 6 professors of palliative care in this room who came to Irene as PhD students or early postdocs. Not even every great scientist can claim that legacy, and it's also not over yet. Anyway, I'm going to go back to the story now. At this point in the story, it would make the most logical sense if I said that since being at the CSI, I focused my research on improving care for people who are dying from cancer. But people with cancer make up a minority of deaths in this country, and yet use the majority of specialist palliative care services. So this is one of the first studies I did when I came here as a clinical lecturer. In it, we asked a really simple question. Who dies in hospices? Who gets access to a hospice death? We used national data over 20 years, and we found that the vast majority of people who die in hospices, actually 95%, had cancer. And we identified significant and growing inequalities in terms of access to hospice deaths. So I started thinking to myself, okay, where were unmet needs greatest? And it didn't take me very long to identify end-of-life care for people with dementia as an area of huge and growing societal need and very, very, very little research focus. But there was something else, because I also felt that the end-of-life care needs of people dying with dementia were kind of being swept under the carpet in terms of the national policy dialogue. So at this time, we'd had the Prime Minister's Challenge on Dementia that said very little about end-of-life care, and we had the National End-of-Life Care Strategy that said almost nothing about dementia. Tens of thousands of people with dementia were dying every year. They were falling through the gaps in policies and not accessing the services that might help them. So, if people with dementia weren't dying in hospices, where were they dying? The place of death is an important concept. First, because most people who express a preference say that they would prefer not to die in hospital. But it was also an interesting concept because there had been such a strong policy focus on dying out of hospital. And I was really interested in examining that among people with dementia. So again, using national data, this time over a 10-year time period, we examined changes in place of death among people with dementia. And we found this really quite interesting pattern. Whereas in the early 2000s, hospital deaths were going up among people with dementia, in about 2005-06, that trend reversed, after which hospital deaths started falling. And 2005-06-07 was when the National End-of-Life Care Strategy was kind of active. So on the surface, this data looks quite compelling, and I think the policymakers liked it because you could interpret this trend as evidence that the National End-of-Life Care Strategy had been effective. But there was something about this data that just didn't really fit, because clinically I saw evidence of increasingly aggressive end-of-life dementia care. I felt clinically, in many ways, things were getting worse and not better. And I realised that there had been such a focus on the place of death in both research and in policy that patterns of care before the end of life had almost been overlooked in terms of the national conversation. So I applied for and won an NIHR Clinician Scientist Fellowship to explore this question of patterns of care before the end of life for people with dementia in more detail, and this was done in collaboration with Rob Stewart at the IOPPN. So the first thing we were interested in was exploring emergency department attendance among people with dementia. I think you can appreciate that the emergency department is rarely the ideal place of care for someone with advanced dementia. So using a South East London dataset, we found that emergency department attendance among people with dementia is common, that it increases exponentially as death approaches. And in contrast to our previous data that showed that hospital deaths are going down, we found that ED attendance among people with dementia was going up, confirming that aspects of burdensome care towards the end of life for this patient group were indeed getting worse and not better. And we used this data to successfully argue that policymakers should consider additional indicators of the quality of end-of-life care, not just the place of death. Now, one of the really brilliant things about having a fellowship like a Clinician Scientist Fellowship is that you can start to grow a team. And I got incredibly lucky through hiring Javiera Laniz as my first research assistant and subsequently PhD student. So Javiera has a background in primary care, and she was really interested in understanding what are the aspects of primary care that are associated with fewer or more hospitalizations at the end of life. So Javiera found, for example, that when people with dementia have their palliative care needs identified in primary care, they then have fewer end-of-life acute hospitalizations, and that palliative care may be the mechanism through which that is achieved. She also found that when people with dementia have continuity of primary care, so when they see the same GP each time they see a doctor, that is associated with fewer end-of-life hospitalizations, which is a really important potential policy lever. Amel Yorganja is another PhD student who's interested in understanding patterns of care from diagnosis, so the point of diagnosis to the end of life. People with dementia can live for quite a long time with that diagnosis. What Amel has found, which is illustrated in this figure, is that actually from the point of diagnosis, most people with dementia have very low levels of hospital admissions, and that level stays low until the last 12 and 6 months of life, so indicating that this really is a last year of life phenomenon. So the research, all of the research actually that I've spoken about so far, uses routine data resources or big data to look at patterns in care. But to really understand what's going on, you need to use additional methods, such as qualitative methods. So Leslie Williamson was a PhD student, now a postdoc with a background in psychiatry. Leslie was really interested in exploring in more detail this question of why people with advanced dementia near the end of life go to the emergency department. And what Leslie found through interviews with people with dementia and their carers is that there's a stigma associated with dementia and a lack of parity of esteem compared to other conditions that, for these patients, gives them a sense that they just don't have a choice. They have no option but to go to the emergency department when they have a problem. So, of course, not every person has an equal chance of going to having an acute hospital admission near the end of life. And actually, all of the studies that I've told you about so far have described inequalities, particularly inequalities related to socioeconomic position. So Joanna Davis, who was a PhD student, now a postdoc, has really put this question of socioeconomic inequalities and end-of-life care outcomes on the map. Joanna showed, and it's illustrated in this figure, that however you measure socioeconomic position, and that's the things around the outside of the circle, and however you measure care at the end of life, that's the stuff in the middle, you see a consistent pattern. People with lower socioeconomic position, they do worse. The question, of course, is why? It's all very well showing that a pattern exists, but to improve the situation, you have to understand the mechanisms that underlie it. So Joanne has found that part of the explanation is because people with lower socioeconomic position have worse health, and when you have worse health, you're more likely to go to hospital. But crucially, she's found that that's only part of the explanation, about a third. And what we're now doing, Joanna's leading this grant, is to explore other broader social determinants that might influence these outcomes. So things like the influence of housing quality and social support in terms of being able to remain at home at the end of life. So we can describe patterns of care for people who are dying and even trends over time. We can identify populations who are more at risk of potentially burdensome care. We can begin to unpick the mechanisms that might lead to those associations. But even that, it's not enough, because if we want this research to have value, we also have to make sure it's used by people who have power to affect change. This is Ian Chalmers. Ian is a true giant of health services research, in my view, someone who has done maybe more than anyone else to ensure that research and evidence has value for patients and for society. Ian has been a mentor of mine for many years. He's agreed to let me say that tormentor might be a more accurate description. And Ian, over the years, Ian has really challenged and provoked me to think deeply about how we can improve the value of the research that we do in palliative care. So my team have found through a series of policy analyses over the years that palliative care is frequently missing from both national and regional policy documents. It's just not there. But almost more of a concern is that when palliative care is mentioned in those documents, there's almost a complete dissociation between what the policy is saying and the scientific evidence base. And as we know, when policies are not based on evidence, that not only causes waste, because it's a waste of research, but it also potentially causes harm to patients and their carers. So the Better End of Life programme really focuses on bridging this gap between evidence and policy. It's a 3-year programme of research that's funded by Marie Curie. The aim is to understand what it's like to die in the United Kingdom and to frame this evidence in a way that compels policy action. The Better End of Life programme started in 2021, and for obvious reasons, a strong focus, although not the only focus, has been on palliative and end-of-life care during the COVID pandemic. As we all know, very early on during the pandemic, policymakers started preparing for the fact that there were likely to be tens of thousands of excess deaths. Inexplicably, palliative care didn't feature in those preparations. So the Better End of Life programme is all about policy prioritisation and policy impact, and this is enabled through 2, I think, quite novel and incredibly important features. The first feature is that we work very closely with the funder, particularly with their policy team. And this close collaboration has meant that to date, our research has been cited in Parliament numerous times, has led to parliamentary questions, early motion debates, all activities that drive policy change. But the second aspect, which I think is equally important, is that the programme includes flexibility for us to respond rapidly and with agility to emerging policy priorities. And an example of that is this piece of work, which is a study where we examined emerging health policies, so integrated care board policies, to see what they were saying about palliative and end-of-life care. Now, this study was prompted by the fact that we knew that there was about to be a debate in the House of Lords about provision of palliative care by integrated care boards. We produced this data, which essentially said that integrated care boards, as they were emerging, were saying very little about palliative and end-of-life care, and it contributed to the success of an amendment to the Health and Care Bill, so Baroness Finley's amendment, that now means that all integrated care boards must provide palliative care as a statutory requirement. So a historic policy change, which we were pleased to be able to contribute in a small way to. So that has been a very fast tour of some of the research, but also some of the important relationships that have brought me to this point. What I want to do now is finish by talking about some of the most important lessons I've learned along the way. First, palliative care is a small research field. We are tiny, but we have a huge potential for societal impact. Palliative care is one of those rare things in healthcare. It's a high-value intervention. It's better for patients and carers, and it's better for society. Palliative care offers a solution to some of the knottiest problems facing the health and care system. But it is too often overlooked and under-resourced. Less than 0.5% of the medical research budget is allocated to palliative and end-of-life care. As you all know, 100% of humans die. Research and evidence are not less important when people are dying. We can't be less rigorous about the tools we use just because improving survival isn't the outcome of interest. Third, progress is being made, but the scale of the future challenge is almost overwhelming. Globally, palliative care needs are going to double by 2060, driven by aging and driven by dementia. So incremental progress won't be enough. We need transformative change. And I think that part of the solution to that transformative change lies in aligning evidence with policy to increase the value of our research. So it's not enough as academics to produce high quality research. We also have to make sure that it gets into the hands of the people who can use it to drive change. And as a team, we invest time in policy engagement, such as this policy briefing, which was developed by Leslie Williamson, about improving palliative and end-of-life care for people with dementia. This policy briefing was launched in May and within weeks had been cited in a parliamentary debate about improving care for people with dementia. But we also have to recognise that this is not a one-way flow of information. It's not about us as academics throwing information at policymakers. We have to build relationships with policymakers, talk to them about their priorities, listen to them, and align our research to address those priorities. But I also think that public engagement is a really important piece of this puzzle too. If we want people to have better deaths, society needs to start talking about it, not least because public priorities drive policy priorities. So we need to empower the public to demand better care. And although public engagement activities like these, they're time-consuming, sometimes they're quite stressful, I do think that they are an essential activity if we want to get that long-term transformative change. Actually, over the last years, I've noticed a real blossoming of public conversations about death and dying. I think there's an appetite for them. Our responsibility is to make sure that research and evidence are part of that conversation. And last, I'm standing here alone, but of course, research is a team endeavour. I simply wouldn't be here if I hadn't been supported, inspired, challenged often by the most wonderful colleagues and collaborators. Now, there are too many to mention, so I won't do that. I won't start naming names, except for one. I do want to say that it is a particular joy to be sharing this evening's celebrations with Katherine. If you'd asked me at the start of this journey, when I was 22, to describe my dream job, it would be this. So, I want to thank the giants who have guided and mentored me to get here. My team who inspire me every day, my colleagues and collaborators who not only support me, but make work just a brilliant place to be. And of course, my funders, Cicely Saunders International and the Kirby Laing Foundation, whose vision and generosity in endowing the Galazka chair is making this work possible. Thank you very much.